Today we're going to talk about discontinuation of medications in dementia. My name is John Swegel, and as you can tell by the first slide, I sort of have a dual role. I'm an associate professor at the University of Iowa College of Pharmacy. Mainly my practice site is in Mason City, which is just south of the Minnesota border, about 20 miles, where I work in a family medicine residency program. And a lot of the experiences that we have up there do tie into geriatrics. As a matter of fact, yesterday we were rounding at the nursing home, one of our area nursing homes, and this very topic came up of a patient that had dementia, and there was discussions about how do you discontinue medications in those types of patients. So I bring to you not only what the literature says, but also some practice tips and pearls, and that's mainly the focus for today. Disclosure statement: I don't have any financial interest or relationship with any manufacturers or products or providers of service I might be discussing. I don't have any relationship with companies supporting this educational event, nor will I discuss any pharmaceuticals, procedures, or devices that are not that are investigational or unapproved for use by the FDA. As a matter of fact, we're going to work on getting rid of some of those medications today. The objectives are listed here. Nothing really too particular to pull out of those. And I want to start off with the case. This is a real case. This is not the lady we talked about yesterday at the nursing home, but this is a nursing home patient that we have had on our service before, and you see that she has dementia as the primary diagnosis. Then has COPD, AFib, CKD, osteoporosis, heart failure, and osteoarthritis. And this is not uncharacteristic to see. And people, of course, as they age, they are more prone to getting various different diagnoses. But this is not uncommon to see either. This is her medication list. And I don't want you to pay attention to the individual medications in this list. Just look at the number of medications. And so one of the things is you have to ask yourself is, well, what's appropriate with this? And in determining appropriate prescribing, I think people like to look at the phrase quality prescribing. We all want quality products and to have quality health care. Nothing substandard is allowed, and that can be challenging. There was data that came out a number of years ago that looked at values and what's judging to be appropriate for prescribing. And there are three things that came out of that. First of which, of course, is the patient desires. And of course, you need to take this with a grain of salt at times, because sometimes you tell patients something and it might be an educational gap. So you need to distinguish between those that actually don't understand what's going on with them, or the family may not quite understand what's going on with the patient. But that needs to be distinguished between those and those who actually do understand, but they don't agree with you. And I'm sure you've seen that. We have patients certainly who are not dementia patients that maybe have poorly controlled diabetes, and you educate them on the importance of that. And they understand it, but yet they don't make the change. And so there's a very challenging distinction between those that don't understand and those that do, but they just disagree. Rationalization for the medication, clinical needs of the patient, and this is, I think, the key area that healthcare can focus on. Why are we using medications? In the residency program I work in, I tell the family medicine residents, I say, my job is to help you with application of knowledge. And that application of knowledge means more than just giving a blood pressure medication for hypertension, but asking yourself, why are we doing that? Why are we using this medication? Why don't we use this other medication? How long do we treat somebody? When do we make changes? When do we decide that our goals are changing? So the rationalization for medication is very, very important. And then, of course, the general good. I mean, that's sort of a mixture of things, that looking at society and family-related issues. But those three contexts are values are what people look at in judging appropriateness. Now, it's not just limited to those as well. However, it is a fine balance between over and under prescribing, and I think that is definitely something to consider when looking at a medication list for somebody who's on 15 or 20 medications. Polypharmacy. That phrase is out there, and it is suggestive of multiple medications, but oftentimes it's associated with inappropriate prescribing. But that's not a fair association. Polypharmacy does not necessarily mean it's inappropriate. I'll give you an example. If you have somebody who has a diagnosis of COPD, if they have heart failure, if they have diabetes, hypertension, hyperlipidemia, CAD, I promise you, if you look at the guidelines on what they should be treated with, you're going to have essentially polypharmacy. But that might be more obligatory polypharmacy because you're following the guidelines. So don't interpret polypharmacy as always being inappropriate. And then, of course, considering the likelihood of realizing the benefit as well as the goals of care. And what this is getting at is if you're using something for blood pressure control, will the patient live long enough, or is the prognosis of the patient good enough that they would realize the benefits of giving them the medication? Concerns that are out there, of course, medications have been very complex. I was at a P&T meeting earlier this week, and the oncology medications that are out there, we had a new one that was approved by the P&T, and I'm not an oncology pharmacist. I can stay in the conversation when these medications are discussed, but if you think about the complexity of targeted therapy in that field, the cost of those therapies is astronomical. So medications, in the pharmacy world, you get into what they call specialty pharmacy. And that means that you have medications that are very specific in what they do. They tend to come with a very high price tag. And these are not medications that you can just go down to the corner drugstore and pick up. They tend to have distribution processes that also are specialized. But I think everyone, in essence, is trying to do what they think is best for patient care. And this includes the family members, not just health care, but the family members are also trying to do what they think is best for their loved one. And so the healthcare system, what are the expectations? Well, oftentimes it's guideline driven, as I already talked about. The fix-me approach of society, if something is ailing them or something is deemed to be wrong with them, they come in and they expect to be fixed. Certainly the healthcare system, you have metrics that are out there, both on the inpatient and outpatient side that tend to be tied into reimbursement. So there are some expectations that are out there whereby people might end up on numerous medications. So polypharmacy, we know, as I said, is not always synonymous with inappropriateness. However, it is associated with increased healthcare costs, adverse drug reactions, drug interactions, non-adherence. And then that last point is the most important, the functional aspects related to the patient, particularly when it comes to dementia. If you look at the risk of falls, cognitive impairment, diminished functional status, all of these things, if you are giving any medication and it is negatively impacting their functional aspects of the patient, those should be stopped. So that's the biggest area in polypharmacy I want you to focus on when it comes to dementia. Adverse drug events, these have been out there. The latest literature I saw on this was a journal article that came out last fall, came out of JAMA, and it's based on 2013-14 data where they look at emergency department visits, and they have 4 emergency department visits for adverse drug events per 1,000 patients annually. 27% of those resulted in hospitalization. And we hear about adverse drug events and how these can lead to hospitalizations, and potentially we can prevent these from happening, and I would argue that in some instances we can, in others we can't. They are just risks that come with using the medications. But interestingly enough, in older adults, and this really hasn't changed that much as far as the medications that are associated with ER visits, but anticoagulants, diabetes medications, and opioid analgesics are the most common causes for older adults to head off to the emergency department. So when you're thinking about that, those 3 classes of medications you should keep in mind. Now for the diabetes medications, more than likely it's the sulfonylureas and probably insulin that tie into that, leading to hypoglycemia. But clearly the anticoagulants, it could be anything from Coumadin to the newer agents, and of course opioid analgesics. So keep those in mind when medications are being used in older adults. So we're going to look at some approaches to assessing medications, and there are different tools out there, there are different methods that are out there, and we're going to go through some of those. But the main tools, they fall into really two big classes or types of criteria. The first of which is explicit criteria, and the second is implicit criteria. Explicit criteria focuses on criterion-based things and developed through reviews, expert opinion, or consensus techniques. And I want you to think of explicit criteria where the focus is on the medication, okay, versus implicit criteria where approaches are judgment-based and use patient-specific information for determining medication needs. So implicit criteria focuses on the patient as being the first thing to look at. And most of the data out there, it falls into the explicit criteria. So for example, things like the Beers criteria, the start and stop criteria. But implicit criteria is probably a better approach. The downside is it takes more time. And I'll show you an example of that here in just a little bit. People can also look at a process versus an outcome approach. The process approach on the left, it talks about an 85-year-old patient with diabetes that is taking glyburide 10 milligrams daily, and hopefully you're not seeing much of this anymore. Glyburide is not a medication that I have recommended for probably 20 years, and particularly in the older people. But if they come into a clinic and it's noted in the clinic that over the past month they've had a few low blood glucose readings. So you look at that, and if you're a clinician, you're saying, well, is it because they are on too much glyburide? Is it because they perhaps have been sick and maybe not eating as much? You may or may not make a change to the medication. On the right-hand side is an outcome approach. Same scenario, 85-year-old taking glyburide, but this patient was hospitalized for severe hypoglycemia. And if you've ever taken care of somebody hospitalized or in the hospital with severe hypoglycemia from sulfonylurea, you know it's not just an easy fix. And in this case, it was noted that the glyburide was started about a month ago. Well, I promise you, on the right-hand side, 99% of the time, that patient will never go back on glyburide. So the process approach is a little bit different than the outcome approach. You hope to avoid having negative outcomes, and clearly that is what we try to do as well when it comes to looking at medications and judging appropriateness. If you notice in the slides, before I move on, that I don't have the Beers criteria listed, nor do I have the start and stop criteria listed, in part because the Beers criteria being explicit criteria, this is commonly applied to nursing home patients. It's not really validated in dementia patients. That came out in the very early years of the first renditions of the Beers criteria back in the 90s. However, it's being applied to that with nursing homes. And I want you to view the Beers criteria as a guide. It's not a criteria for inappropriate medication use in the elderly. It is a criteria for potentially inappropriate use. And being explicit criteria does focus on medication. So examples of that, sulfonylurea is one example where they are not preferred in the elderly, and I would completely agree with that. Other medications that are in the Beers criteria would include diphenhydramine. And the key thing with diphenhydramine is that you need to find out why are they on it. So if they're using diphenhydramine for sleep, then clearly that's not an appropriate use for it. However, if they're having a rash or an allergic reaction, yes, it is a very useful agent for that, and it would be appropriate no matter what the age is. Other medications that are in the Beers criteria, for example, meprobamate, is not considered to be appropriate in the elderly population. I would argue that meprobamate is not appropriate for any population. So don't look at it as strictly a hard and fast rule that if somebody is on a medication that's in the Beers criteria, that it's an absolute no-no. But I would ask you to use common sense and to inquire as to why they are on medications that are in the Beers criteria. So this medication appropriateness index, this first one is designed to look at discontinuation of medications that otherwise are indicated late in life. It's not limited to dementia, but it certainly is applicable. And it was motivated by the challenges of polypharmacy. This is a type of implicit criteria. So again, the focus is on the patient rather than the drug or the disease state. And that's what I like about this. It's not a new idea or a new approach, but it certainly is a useful one. This is basically broken down. They have a model that has 4 items to it in sort of pillars. I'll show you a picture of that in the next slide. You consider the remaining life expectancy, the time until benefit, the goals of care, and the treatment targets. And then they also look at 10 elements of prescribing to ask when addressing medication use. So that graphic, and I apologize if you can't read this very well, but it does depict the concept. And you see at the very bottom, right in the center, it says appropriate medications. And you see how bigger that is compared to the top of that. If you look at the far left, then you have more time versus less time at the top. And if you look at the far right, is it a curative approach or is it more of a palliative approach? And then you have those pillars. So remaining life expectancy, time until benefit. Then you also have the goals of care and the treatment target. And the concept behind this is if you have more time and you're going after a curative approach, your bucket of what's potentially appropriate medications is a lot bigger than it is if you have less time and looking at more of a palliative approach. So what determines that? Well, the time until the benefit. So if you have an 85-year-old that has diabetes and the diabetes has been reasonably controlled, when do you expect them to have complications from diabetes based on the prognosis of the patient? I would argue that they have less time just based on their physiologic age compared to somebody who is perhaps 65. You also have to look at the goals of care. The key thing with the goals of care is, have they changed? So are the goals the same now as what they were 10 years ago when they started a medication for whatever the indication is? So that's the concept in looking at this medication appropriateness index. The other aspect in looking at those 10 elements, and as you can see at the bottom, I highlight that there are some clear indications for unnecessary polypharmacy. And the first one is there any indication for the drug? So if there is not an indication for the drug, and I don't care what the age of the patient is, get rid of it. Whatever you do, don't make up an indication to keep the medication on board. If you can't find an indication for the medication, there's no reason for somebody to be on it. Secondly, if they are on a medication, is it effective? If the medication that they are on is not doing what it is supposed to be doing, then there's no reason to continue it. And again, that's applicable to any age population, but particularly true in older individuals. Is the dosage correct? Well, that is somewhat dependent on the indication for the medication. Are the directions correct? Are the directions practical? Oddly enough, many, many years ago, there was a drug called Tacrin or Cognex, which was the first of the cholinesterase inhibitors out there for dementia. And the frequency of use for that, it had a lot of adverse effects, but people were expected to take that 4 times a day. That's not practical in giving somebody with dementia a medication that they take 4 times a day. So you know they're probably not going to be doing that. Are there any clinically significant drug-drug interactions? And this is a difficult one because if you look at the computer programs that are out there that look specifically at drug interactions, you see this in your clinic with EHRs, you see this in the hospital. They pop up quite a bit. The question is, are they clinically significant? Earlier this week on rounds, the residents were asking me about QT prolongation because they had somebody who was on a amiodarone, I think it was, and they were thinking about giving them levofloxacin, and then it popped up of QT prolongation. And that drug interactions in and of itself is a talk. So I don't want to belabor that point anymore, but the key aspect of that is you will have drug-drug interactions. Your job is to determine if it's clinically significant or not. Are there clinically significant drug-disease interactions? Same concept as above. Is there unnecessary duplication of drugs? And I would argue if there is, then start stopping some of those. Take some of those away. And then finally, is the duration of therapy acceptable? And then finally, is the drug the most cost-effective choice? And notice that is the last thing on this slide because I don't want cost to be the driving factor in this. I want benefit for the patient to be the driving factor, but clearly cost will factor into that. Limitations with this approach. Clearly, the number one limitation is it takes time. You have to know the patient. You have to understand that that the patient and the family, they all factor into that second point, or that second limitation, and that is the challenges of goal setting. It's difficult conversations to have with patients when you're talking about taking medications away, looking at prognosis and that sort of thing, but we have to be honest with the individuals that we are dealing with, and including the family. And then medication recommendations in the elderly are limited by lack of adequate representation in clinical trials. When I go into a nursing home and I see a patient with dementia that is sitting in a wheelchair looking out the window, it's not my role, and I don't think it's our role, to determine what quality of life is. I think that's up to the family and up to the patient. Clearly we have our biases on that. However, I think our role should be, and I would encourage you that our role, especially in dementia, is to protect the safety of the patient and also to maintain the dignity of the patient. Those are two main factors that we are involved with, and those should take precedence over us trying to determine what's good for quality of life. Reducing medications. When you are in conversations with patients, you want to avoid having this perception of giving up. So if somebody, let's say, was told that they need to be on a blood thinner the rest of their life, and you go in and you say, you know what, you don't need to be on this medication anymore, then they may think, well, that must mean I'm going to die. Or you are pulling away from medications that for years they were told they have to be adherent to. Take this every day or twice a day. We're going after these goals for your diabetes, and now you're pulling back on that. People can perceive that as you're giving up on them, and that's not what we're trying to do. We're trying just to simplify medications. And then that goals of care, have they changed? As we've talked about, yeah, I would argue they have. As people get older, what is important to them, the goals, the metrics, all of those, they probably have changed. However, there are people that have goals that are probably not realistic. We had a patient in hospice one time that had lung cancer, and their goal was to see their grandson graduate from high school. And of course their grandson wasn't graduating for another 4 years. So is it a realistic goal? Well, short of divine intervention, probably not. Keep in mind the families, though. The families, and this is just an observation on my part, I don't have any hard and fast data to back this up, but I'm sure all of us have seen this. I know I've seen it a number of times, I'm sure you have too, where the family members come in and they're not in agreement. They may say, well, I want to do what's best for mom or dad, and I do think that that's true, they do. However, the thing I think that a lot of people have is I think they have feelings of guilt. So an example of that is a relative that lives off in another state, they don't make it back that often, and then all of a sudden their loved one is taking a turn for the worse. They come back, they visit, and they want everything done. Well, part of that probably is a feeling of guilt that they didn't spend as much time with that person as they should have. And I've seen that, and I think you have too. It does require education on the part of healthcare, though. What, again, is realistic for a goal? What are the wishes of the family? What are the wishes of the patient, the other providers? The number one thing that we have to keep in mind is the wishes of the patient, because they do take precedence over anybody else's wishes. And but we just need to make sure that everyone's in agreement with the plan of care, because if you have one person that is not in agreement with that, then things don't oftentimes work out for the best. Methods to reduce medications, I put in here the low-hanging fruit, the ones that are pretty easy to get rid of. The first of which is the patient doesn't want it. So you may go and into a nursing home, for example, and the patient may be getting a medication on a scheduled basis, and they're refusing the medication. And you see the circles every day when the patient does not take the medication, and they might end up taking a chronic medication 30% of the time that month. They're telling you something. they're telling you they don't want to take it. And so I would argue that we probably should stop the medication. And I also would suggest that there's no data out there or evidence out there that shows if you treat a chronic condition for 30% of the time that it has any positive effect on the outcome. So the patient could tell you something even though they may not be able to verbalize it to you. If they can't take it, maybe they are having difficulty swallowing. Maybe the medication that you're giving them is a big pill. And if you've not seen some of these pills that are out there, you should really take a look at them. Every time you write for a potassium pill, those are pretty big pills to take, and some people have difficulty with that. If they aren't using it, this is mainly focused on the PRN medications. Clearly, if somebody is not using something for months at a time, there's no reason to have it as an option for a medication. You can always reorder it. If there's an adverse effect from it, then I would suggest that we need to readdress the benefit that you're trying to get from that medication, or if they don't need it. And that's, to me, a big one, because who determines that? Who determines if they need the medication versus not? That's challenging. I'm not going to mix words on that one. It's a difficult thing to determine need versus benefit. But if you do determine that the patient does not need it, then I would argue that that's a reason to get rid of it. The brown bag approach, this has been out there for a long, long time. The concept, and this is more for ambulatory type patients, but the concept is that if you have somebody who comes into the clinic, have them pack up all of their medications, their prescription meds, their OTC meds, any herbals that they may be taking, supplements, vitamins, whatever they may have, and bring everything they have in a brown bag in to see you. And then that allows you to see what they have at home. It also provides you an opportunity to get rid of medications that are no longer needed. And I promise you're going to find some duplication of therapy. Medications, of course, are started and stopped. And your job, though, is to try to limit what they have and minimize that. Your job is not, by the way, to take the medication and dispose of it. It's their property. Many times my office at the residency was a medication dumping ground where people brought their medications in. The physicians went through it, and the patient didn't want it anymore, and so then I go upstairs, and on my desk sits a bag full of medications. It's their property. Controlled substances are definitely something that we want to dispose of appropriately. Fortunately now in law enforcement, you can take them to the sheriff's office, and they have the take-back bins, so you can dispose of them, and they do get taken care of properly. And then also, it's an ideal situation with this brown bag approach to review medications that at every visit. It's not practical to do it at every visit, but occasionally you want to do that. You also may find people that come in with a script or a bottle full of antibiotics, and they hung on to them because it cost a lot of money and they don't want to get rid of it. I understand that. We just need to make sure that they are storing them appropriately and not using them without guidance from providers. Avoidance of the prescribing cascade. This is sometimes easier said than done. Using an NSAID. So clearly there are some instances where we do need to use an NSAID, but that may lead, of course, to the addition of a proton pump inhibitor or an H2 blocker because of the GI issues, or perhaps they have edema as a result of the nonsteroidal, and so you need to do something with the diuretic. Or then that might then lead into low magnesium or low potassium, either from the proton pump inhibitor or the diuretic, and so now you have to look at supplementation. So you've seen that prescribing cascade before, where you're giving a medication essentially to treat an adverse effect of another medication. So if we can avoid that, that's ideal. I fully understand that that's not always the easiest thing to do. And then therapeutic holiday. This is something I think that we miss a lot. I've seen a lot of patients that when you stop a number of medications, what do they tell you? They feel better. And that's what we kind of want in a way, especially at the end of life or in dementia patients. But a therapeutic holiday, there's nothing out there that says you cannot restart something. And I promise you that a lot of people miss this. They think that they have to be on these medications, and providers think they have to be on these medications. Well, you can stop it for a while, and then see what happens. But clearly, you can always restart something if a symptom comes back or there's a need for it. So how do we reduce medications with coordination of care? I can't fix this. I'll be up front with you. We have multiple disease states that are out there, and that oftentimes means you have multiple providers involved. And each one of them, rightfully so, focuses on their own area of expertise. So the challenge with this is, in the clinic that I work, the primary care docs, they will not touch a medication that was prescribed by a cardiologist or a neurologist. But if you have people going to multiple different providers, you can imagine that you're going to have multiple different medications on board. And if we don't have coordination of this, then that can lead to multiple or polypharmacy, I guess. But it's difficult to address and difficult to fix. Communication is lacking. I think that's true in all of healthcare. We try, but effective communication has to be an essential component of this when trying to get rid of medications. And if it doesn't happen, then it's highly unlikely that reductions in medications will occur. So appropriateness of medications. What is optimal prescribing? Well, that rests on efficacy and safety. And again, in dementia patients, in addition to safety, it's dignity. So the appropriateness and cost effectiveness of medications are both secondary things to look at. Your main thing is to look at efficacy, safety, and dignity. Consider relaxing your goals. So nursing home patients, end-of-life care, we're finding guidelines. This is always a challenge because the guidelines had set goals. And people like to follow evidence-based medicine and follow the guidelines, and that's certainly appropriate. However, as people age, as their physiologic and chronologic age occurs, we need to consider relaxing the goals. And the guidelines, fortunately, are starting to show that. If you look at the JNC-8, for example, if you look at the standards of care from the ADA for diabetes, they are allowing you to have less aggressive goals because we want to help maintain that patient's safety. So that is something that we need to take the approach of when we go on and discuss with plan of care for patients, especially in dementia. So the primary intent, and this is something that you would have to address, the intent of the medication is important in determining continuation. And again, the premise of this is looking at patient functionality. If you discontinue a medication, does it negatively affect their functionality? If the answer is that it does affect their functionality, then you need to keep the medication on board. Okay? Any medication that does not benefit the patient and is not given for symptom management should be stopped ideally. I realize that this does not always occur, but the primary thing in looking at discontinuing medications is you want to look at, will it affect the functionality of the patient? Patient perceptions, and you can probably expand this to perceptions of the family, and again, I want to avoid the perception of giving up. But sometimes patients, they have medications or treatments that they take that they're not really benefiting from them, but it's also probably not hurting them, through an example of a vitamin or minerals. And this may provide a means for patients to have some control, because if you think about it, they go to see their doctors and they're told that they need to be on these medications and these are the goals of care. They need to be adherent with the medications. And now we go in and say, nope, we can stop some of these now. And the patients, they want to have some autonomy, and I don't blame them for that. So if someone feels better taking a vitamin every day, I don't care. That's fine. They can continue doing that. It does not bother me at all. And sometimes patients and families may want to continue with the status quo. My neighbor, a number of years ago, who, like right next door neighbor, was diagnosed with lung cancer, and he had diabetes, and he was in hospice, and he still wanted to take his Lantus insulin. And his wife wanted me to come over and give it to him because she refused to, because she didn't like to poke him. So I said, okay, I'll come over and do that. I can do it every night if you need me to. And this neighbor's name was Jack, and Jack felt determined that he wanted to do it himself. And I said, that's fine, Jack. So I'll pinch your skin and you go ahead and inject yourself. And he took that pen device and he jabbed that thing in there, bent that needle, squeezed the trigger, and the insulin just went everywhere. Didn't get into him at all. I didn't care because he felt like he was in control of something. And that is what helps to maintain the status quo for him. That is what gives him some autonomy. And that also helps him maintain some dignity. However, there are some patients that you say, you know what, we're going to get rid of some of these medications. And they may be relieved by that. They're getting away from the burden of taking medications. I think I've encountered one person in the past 20 years that actually enjoyed taking a bunch of medications. And these are not Munchausen type patients. These are patients that had chronic conditions that had numerous medications and they had it all laid out in a tablet. But the majority of people, the vast majority of people will tell you they take too many pills. So there may be some relief from patients if you say we're going to start tailoring back on that. Risk versus benefit. Again, if the risk outweighs the benefit, clearly get rid of it. The approach is very similar as we talked about with the medication appropriateness index. Rather than looking at time to benefit, looking at time to harm. And that's something else that we need to be cognizant about. This is something that I urge you to do, which is challenging at times, I realize, but if you are coming to the conclusion that and willing to stop a medication, then I'm questioning why we still monitor for whatever that disease state is. To me, it doesn't make sense because let's say if you stop a diabetes medication and you continue monitoring the blood glucoses, they're going to be higher than what they were. Hypertension and blood pressure monitoring, same thing. If you stop an antihypertensive and their blood pressure starts creeping up and you're looking for that, well, that may lead to them going back on the medication. So if the decision has been made that some of these chronic medical conditions no longer need to be under tight control, we can tailor back on that, but I also would tailor back on the monitoring of that. But all caregivers and family need to be in agreement with this, and that's one of the challenges of nursing homes too. And I'm sure that if you do anything with nursing homes and follow patients in nursing homes, you know that they have to be in constant communication with you, and anytime there's a lab abnormality or vital signs or blood glucoses, they're quick to fax you that information. So it's a little bit more challenging in that setting. So how do you actually stop medications? Well, you can just abruptly stop them. I don't think that's a wise approach for all medications. The only time I would advocate for that is if clearly if harm is present, then you need to stop the medication that's causing the harm. That goes without saying, I think. But if you have somebody who is on a bunch of medications, just absolutely stopping everything without thinking about it, I don't know that I would take that approach, but it is one approach. Tapering medications down, that's a very easy way to do it. So they may be on a whole bunch of medications for diabetes. Well, let's start backing off on the dosages that they're on. Selective withdrawal is one that I usually use, and we'll talk more about this a little bit later. I first look for high-risk medications because, to me, I want to minimize the harm to the patient or potential for harm. Medication is not likely to provide benefit is sort of the next approach I take, and then medications which are difficult to take, which, again, the patient may be already telling you that by refusing to take the medication, but selective withdrawal, I think, is a very effective approach that can be used. Now, focusing specifically on dementia, this is challenging because aligning the goals of care, dementia in and of itself, as you know, the progression from mild to end stage, it can take a number of years. And it does not have a predetermined course whereby people are declining at the exact same rate. Optimize medications. So, challenging part because, again, you're focusing on the quality of life, looking at the benefits versus the harms. My father, as a matter of fact, was diagnosed with Alzheimer's disease back in 2010. And later in the progression of his disease, he lived in Houston, Texas, and he was enrolled in hospice, and my father had issues with, he's a kind man, don't get me wrong, but the dementia was bringing out some anger issues and some pain issues, and and he would get aggressive. And my stepmother texted me one night, and she says that that the hospice nurse was there, and they increased my dad's quetiapine or Seroquel, and that he's doing much better with the increase in dose. And then I said, well, what dose is he on? She said 500 milligrams. And I said, what? 500 milligrams? Do you mean 50? And she said, no, 500. So I had to take my hat off as a pharmacist and put my hat on as a son and go by what she had told me earlier, that he was benefiting from that, even though the dose was grossly higher than what I would ever think about using in dementia. But it's benefit, okay? It's the benefit that the patient is receiving. The challenges that come from dementia, clearly, when it comes to families as well, decreased decision-making with the patient themselves, caregiver goals, established beliefs, lack of time on the healthcare provider side. Those are not any different in many different situations, but clearly are highlighted as challenges in discontinuing medications in dementia. When they become more advanced, and I'm going to talk about these from a literature standpoint first, and then I'll go into my own biases on these medications. But the first up is the cholinesterase inhibitors, and there's little evidence out there on when they should be stopped. There's some evidence or question of evidence on should they ever be started, but we won't get into that. But if you have patients on them, some evidence will state that worsening behaviors after stopping donepezil, that's out there. I've seen that. We had a hospice patient one time that was on donepezil, and they were enrolled into hospice, and we said, we need to get them off that medication. The family says, well, I wouldn't do that because the last time they tried to take him off of it, he got worse with behaviors. And so do we listen to him? No, we did not. We took him off donepezil, and guess what happened? The behaviors got worse. So we put him right back on it. And it did help with that. So there are those instances that are out there. So keep that in mind. But the main focus of the cholinesterase inhibitors is slowing the progression of disease or slowing of decline. If that is no longer the goal, or if the quality of life is poor, then treatment with cholinesterase inhibitors is no longer appropriate. Now, at what point of time is that? I don't have an answer for that. I would argue that if somebody is bedbound, if they are not recognizing people, if they're not communicating, sleeping most of the day, clearly that one, it's inappropriate to use. However, when people go into the nursing home, I don't advocate stopping these medications when they go into the nursing home. And the main reason is because they're having a change of environment. And I want to get them accustomed, at least somewhat, to that new environment. But you could feasibly consider backing off on these medications in your nursing home patients. Cautious discontinuation is recommended, is how I put that. But nonetheless, cholinesterase inhibitors are ones you will encounter. Memantine or Namenda is in the same context. The limited data suggestion is to discontinue. But again, I have seen that one used in helping to control anger in really case reports mainly. Statins. The literature will say that the benefits are realized only after a period of months to years. I'll talk more about that later. This is, again, focusing on the literature. But in the absence of an acute coronary syndrome or a stroke, discontinuation would be reasonable in advanced dementia, and I certainly agree with that. Antimicrobials, not really looking at one in particular, but the aggressiveness of treatment really is determined by the advanced care planning. How many times are you going to treat a urinary tract infection with antibiotics versus treating with something else? I think we get lost in the concept of not being on an antibiotic means that the patient will suffer. No, that's not clearly what I'm saying. We have other means to treat patients as far as their symptoms go that do not involve antibiotics. But give consideration to withholding antibacterial therapy and provide symptom relief. I had an internal medicine physician, an older physician, that told me a number of years ago that pneumonia is an old man's friend. The concept meaning that an acute infectious process can sometimes be better off for the outcome than having to continue in life with suffering and pain and that sort of thing. So I am not a proponent of using antibiotics for every infection that comes in, especially when you're looking at goals of care. Other medications in the literature, it's driven more by opinion, and I'll share with you some of my opinions on those. Diabetes medications, they are not life-sustaining, and the risk for DKA is low. Clearly, if you do happen to have a type 1 diabetes patient, you don't want them to go without insulin, but I would argue that your risk for hypoglycemia would warrant backing off quite a bit on the insulin dosing. A lot of times with diabetes medications that I look at is the oral intake, again, predominantly looking at the hypoglycemic agents like sulfonylureas. And as their oral intake declines, then you clearly need to watch out for concerns about hypoglycemia. Antihypertensives, if their blood pressure is low, obviously you want to back off on those. Anticoagulants, I don't want to talk too much about that right now. I have another slide talking specifically about them. But nutritional intake is vitally important. So again, if you have fluctuations in nutritional intake for drugs like warfarin, then I would argue you need to consider stopping it. And then finally, in the literature, at least, the medications for osteoporosis, limited evidence of efficacy of calcium and vitamin D, especially if they're immobile. Bisphosphonates, they may be contraindicated, clearly, if they can't take them as prescribed by sitting up and not laying down for 30 minutes. And then the question is, will the patient actually see the benefit from that? And I subscribe to the point of view that bisphosphonates are good for 5 years and then done. Then look at other options. The rank L inhibitors like denosumab or Prolia is becoming more and more popular rather than some of the injectable bisphosphonates. But in dementia, I'd have to have someone show me the benefit of a bisphosphonate because I don't think they are appropriate. So here's my take on some of these medications. Warfarin. As I mentioned earlier, when I look at a list of medications, the first thing I look at is the high-risk medications. And warfarin is certainly one of those. The first question I always ask is, why are they on it? Because if somebody, say, had a DVT or a PE diagnosed 3 weeks ago, well, they probably still need the anticoagulant versus somebody that has atrial fibrillation and maybe does not need the anticoagulant. Dietary intake, again, is vitally important for warfarin, as you know, and as that fluctuates, your INRs are going to fluctuate. And if you do encounter that, then it's probably best to discontinue warfarin. So then the question is, well, what about the newer agents? What about the Pradaxas of the world or the apixabans, rivaroxabans, those types of things? I would throw them in the same boat as warfarin. And the reason I say that, and one thing that's not on this slide that probably should be, is what is their functional status? Are they at risk for falls? Do they have history of bleeds, be it GI bleeds or nosebleeds or something that would warrant you saying you got to question the use of anticoagulants in general? So I would throw the newer or the novel agents into the same category as far as do they continue versus not as I would warfarin. Diabetes medications, again, the key thing with this is your goals of therapy and what risk they have for hypoglycemia. Simplify regimens as best you can. As you see, I have insulin regimens, basal bolus, question mark. I would argue that basal bolus insulin in end-stage dementia, when you don't know if they're going to eat or even how much they're going to eat, that is a challenge. I do support using basal insulin. I think that that's okay to use that. You're less likely to get in trouble with that, even if they don't eat. The dosing of the basal insulin might need to be adjusted. But the basal bolus is somewhat challenging, and I also would argue that anybody's getting basal bolus insulin, especially a dementia patient, what happens to them? They get poked multiple times a day because they want to know what the blood glucose is. So if we can minimize the monitoring by simplifying the regimen, to me, that makes more sense. I've already talked about sulfonylureas and sort of hammered that point home, so I won't belabor that anymore. The rest of the agents out there for diabetes, there's no need to be aggressive, and I would say that an A1C of 8% is fine. In somebody with dementia, maybe 8.5%, that's fine. They can float a little high, you won't get in trouble unless they get a little bit low. The newer agents themselves, they're very expensive, as you know, and the good news is you don't have as much of a risk for hypoglycemia. However, I would ask the question again of what is your goal, because it should be backed off on A1Cs. Urinary incontinence medications, especially in dementia, and I'm looking more at overactive bladder and the use of anticholinergics or antimuscarinics. These agents, yeah, the effect of the anticholinergics is more pronounced in demented individuals, and so we all know that anticholinergics can worsen symptoms of dementia, cause more confusion, dry mouth, dry eyes, constipation issues, and I would suggest that you look at, are they getting efficacy from that? Because the efficacy for the antimuscarinic agents is marginal at best, and if you add in dementia, I would question that, I really would. Regular toileting is preferred, obviously not always feasible. There are adult diapers that can be used. I understand that you have to think about skin issues. I also understand you have to think about the cares that are involved with using adult diapers. However, again, I would focus on trying to minimize the risks of adverse effects, and I'm not a big fan of using urinary incontinence medications in dementia. Statins, lovastatin, atorvastatin, rosuvastatin, all of those. Question would be, what is the intent? As mentioned in a previous slide, if they had an acute coronary syndrome issue, then yeah, you might consider continuing with that. We were at a nursing home yesterday, and this is a situation that, as a healthcare person, you love to hear. There was a patient newly admitted to the nursing home that we saw for the first time yesterday. She's in her 90s, I think, and she had recently suffered a stroke. And she had some limitations, both functionally. However, her cognitive aspects were still there, hard of hearing. Toward the end of life, you kind of got that. She was frail, but the nice thing is that the two sons and the daughter were all there, and they were asking about hospice. They were saying that we just want what's best for mom. We want mom to have quality now. And so what is the best avenue we can pursue? And we're thinking about hospice. And whether or not she's appropriate for hospice under the Medicare rules, I don't know. That would have to be entertained, but they were going to do a hospice referral. So why am I telling you this? Because she was put on a statin, and she recently had a stroke. So you may ask the question, is it appropriate to continue the statin? And I mean, that's a decision that I don't know if there's a right or wrong answer, but you could make the argument that since she just had a stroke, an ischemic stroke, that you could say that a statin might provide her benefit in the short term. Most of the time, though, the benefit of statins is not realized for months to years. Antihypertensives, simplify. Simplify as best you can. Do not place the patient at increased risk for falls. Clearly, if you look at not just blood pressure but heart rate, those factors can also determine whether or not to use antihypertensives. Antiplatelet agents, I didn't talk about these in the anticoagulant section, but it would include the aspirins, the prasugrels, the clopidogrels. This is looking at intended purposes as well versus the risk of adverse effect, namely bleeds. I certainly understand that bleeds probably are not as abundant or as common with these antiplatelet agents compared to anticoagulants. However, when you have multiple antiplatelet agents on board or antiplatelets in addition to anticoagulants, then you have to question the benefit. So looking at the intended purpose for using antiplatelets, can we minimize these? If nothing else, get down to maybe a baby aspirin a day, but then again, is that ideal for this patient population? So we tend to get rid of the antiplatelet medications especially in end-stage dementia. So in conclusions, the conclusions are medication regimens, they do need to be individualized. That goes back to the medication appropriateness index I had talked about earlier. Yes, it takes time. I understand it takes time. I would advocate, if you can, maybe pick your high-risk individuals and focus on that. It does involve goals of care, and that, I think, is one of the predominant things that drives this whole idea of medication discontinuation. Keeping in mind your main focus should be on the functional aspects of the patient when it comes to the end stages of life, particularly if people have dementia. And then education and communication. Everybody needs to be on the same page. Everyone needs to hear the same message. And that's I think, the goal of the healthcare team, is to address these with the patient, address these with the family as best we can, and hopefully that would lead then to appropriate medication use. And with that, I will conclude, and I thank you for listening. And if you have any questions, you can certainly send me an email or call me. I'll be happy to answer them, share more information. So thank you.